Good evening, dear colleagues. I'm glad to be talking tonight in this webinar. First of all, I would like to thank you for prescribing and participating, and a big thank to Dentlink for their kind invitation. I'm Karim Corbani. I'm a senior lecturer at St. Joseph University, Department of Restorative and Aesthetic Dentistry. I will be sharing with you tonight how to start our smile design with good parameters to be sure how to succeed our cases. You know, nowadays this app is used basically every day by everyone to make sure how to get to our destination with the best and the sure way. Why don't we apply it into dentistry and make our patients see and approve their cases even before touching their teeth, and make the success rate really higher, reduce the failures, and make our work more repeatable and predictable. So this will be based, and we have to respect design, the selection of the material, the performance or the cutting, and finally the bonding. And this is the way how we finalize. But always we start with the design. You know better than me that now it's the era of aesthetics. It starts with the medical field, with the skin rejuvenation, with the wrinkles treatment, fillers, Botox, and into the dental field in the teeth rejuvenation. And you know, we have a big demand and a huge demand from our patient in this field. These patients are really demandful and picky. So how to make our work more reproducible with less risk of failure? All this will start with a full photo shooting. Usually we were used to use the SLRs with all the accessories, mirrors, retractors, filters, etc. These still a very good option, but practically we can use also what we call this small device, the MDP. MDP device was invented by a friend of mine, and you know him, I think, Dr. Luis Hardan. And the photos you're gonna see during this webinar are done exclusively with this device. So this patient came to our practice. He's a 25 years male patient, complaining from the coverage with the lip of the upper jaw, complaining with the wear on the laterals and canines. A full set of photos has to be taken at rest, at smile, and see the position of the lip and the ratio between the exposure of the centrals with the upper lip. Lateral photos were taken. You can see the gummy smile on the premolars, the wear on the centrals, and how the centrals are eroded distally mainly. So after a full set of photos in occlusion, in protrusion, full analysis of the case, these are the main parameters to be taken into consideration. A wax up was performed by the lab. This is really the conventional work. What about the wax up? We have to send to the lab parameters or indications to perform a very good and reliable wax up, starting with the length of the central and the thickness we want to add on the teeth buccally. So in this case, we did a small mock-up with the composite without etching and bonding, and we decided to lengthen the centrals of 1.2 millimeters, and to add buccally on the central 0.5 millimeters. So the impression was sent to the lab with this recommendation for the central, and from there the lab will work tooth by tooth, respecting the golden proportion. So we lengthen of 1.2 millimeter and we added buccally 0.5 millimeter. This is the technique we were taught, and we were taught to use conventionally. You can see even the surface texture on the wax up, the angulation, the morphology, and the proportion between the teeth. And on this wax up, we can decide where to work on the gum level in case of gummy smile or disharmony in the soft tissue. So this was the conventional way. Another case, a 30 years male patient came to our practice with a diastema between the gap between the centrals, discoloration on tooth number 11, broken teeth a little bit. So what parameters we're going to give to our lab here to do the wax up? Here, we decided to keep the central on the same length, because at rest position and smile position, we can see easily this tooth. A full set of photos was taken. And then we asked the lab to add buccally, mainly on the premolars, to open what we call the buccal corridor and close the gap. And this case was done by the digital workflow, starting with a scanner of the actual case. So before any cutting, before anything, we took a scan. We gave the lab the recommendation to lengthen the tooth number 21 at the same level of tooth number 11, to work a little bit on the anatomy, close the gap, and make the proportion between the teeth. And we opened the buccal corridor of 1.5 millimeters after sending these parameters after a small mock-up in the mouth. So the lab did a digital wax up upon our recommendation. From there, he printed and sent us a printed model. On the printed model, we did a silicone key. This silicone key was used with a self-cure resin temporary material, and we did the mock-up in the mouth. At this stage, it's the step to get the patient's approval after all the remarks, taking into consideration all the remarks of the patients, starting with the shade, then the shape of the teeth. For example, here we saw that tooth number 11 was a little bit wider than tooth 21, was a little bit bulkier, so we gave the instruction to the lab to make it thinner at this point, and a little bit open a little bit the embrasure to make it more flat and less thinner. So after patient acceptance, we analyze the smile, the exposure of the teeth, relation of the centrals with the upper lip, the lower lip, and mainly the pronunciation. If all is good and fine, we can ask the lab to confirm. We confirm the wax up. If not, we can do all the small modifications, and from here we can start the cutting with a minimum invasive. You know, we are at the era of non-invasive dentistry. You can see how thin is the finish line all around the teeth. So cutting of the upper 10 teeth with minimal invasion and polishing of the preparation. Here we can see the scanner after preparation. From here, the lab will take the wax up, the digital wax up did previously, and match it on the preparation, and milling the ceramic pieces and sending us the final veneers already milled upon this initial wax up, digital wax up. We can see the details on the ceramic, surface texture, rounded angles, proportion between the teeth, emergence profile. All is well and nicely done. After cementation of the case, so the case is really predictable. What we saw on the digital wax up is realized on the final thin ceramic veneers in a conservative way and in a predictable way. These veneers were done with Emax blocks milled, full monolithic HT. This another photo of the case after cementation. You can see we closed the gap, the centrals are equal in width, and we have a proportion, and we reduced the black triangles on the lateral sides. This is the case before. This is after minimal preparation with a thin finish line, and this is 1 week after cementation. You can see the integrity of the teeth in the periodontal tissues. So how we did our preparation? So from the digital wax up or the conventional wax up, we used our mock up. So the previous case was taken with a normal conventional impression with the wax up. A silicone key was taken using the self-cure resin, temporary resin, implementation into the patient mouth, removal of the exceeding material, removing of the silicone key. At this stage or this step, we can analyze the smile, the position of the centrals with the lips, even in a conventional way. And you can see even the surface texture on the temporaries, the harmony between the teeth, and so on and so on. So different photos. At this step, the patient can confirm the color or ask different color, lighter, darker, etc. He can ask to lengthen the teeth, shorten the teeth. He can ask to make roundation on the angles, make our teeth with different shapes. We can adjust on the mock-up with any composite material, flowable or any other composite material. After confirmation of the shade and the shape, 3 burrs are enough to do the preparation. A gauging burr, a conical high coarse burr, and a polishing red coarse burr. Sure, with magnification, it's better because we have to drop a thin, very thin finish line, and with a high torque handpiece and with the LED light to enhance the work and to be sure of the clearance of the margins. How the guided preparation to get a real non-invasive case will be done through the mock-up. On the incisal edge, we need like 1 millimeter groove. On the buccal part of the tooth, we need 0.4 millimeter in the middle. And on the cervical, even on the incisal part, but in different position. On the incisal, we're almost 45 degrees with the tooth. In the middle part, we're parallel to the tooth, and on the incisal edge, we are more with an inclination palatally. And this will be the final shape of our veneer. Coming back to our case, we have to shorten the incisal edge 1 to 1.2 millimeters, and then 3 other grooves above this line of 0.4 millimeters depth with the gauging burr on all the teeth. These are the grooves, incisal grooves, and 3 other grooves above this line. So we removed the temporary, and you can see that we did not touch to the length to the teeth, even little bit on the margins, on the central, on the incisal edge. On the other teeth, we didn't touch the teeth. So this is a guided, really non-invasive, little to no prep technique. Some adjustment of the gum levels were done with the diode laser at the same session. Inclination of the burr on the cervical part is 45 degrees with the tooth. On the middle part, it's parallel to the crown, and on the incisal edge, it's little bit with a little bit inclination to the palatal wall. What if we have gaps or spaces between the teeth? It's recommended to keep our margin as much as possible on the palatal walls to close the gap from the palatal to the buccal part and cover all the crestal part. This way the patient will not feel a concavity or a void on the palatal side. Conventional impression, if we are not using a digital workflow, and from here the temporization. Temporization, you can see all the details, the color, the shade, the shape, the harmony between the teeth, the position of the centrals with the lips, with the upper and lower lips, even as we discussed the surface texture. And this is after polishing of the temporaries. Here you can see that the color is a bit white, so we discussed with the patient and we decided to do it a little bit darker. This was a B1 color, so we went for A1 shade for the final veneer after milling. So this is the case after cutting with really minimum prep, with the full surface really polished, with a thin finish line all around the teeth. So we're still in the enamel, we're bonding to enamel, different photos from different angulation. In this case of diastema or gaps, we go with our margin to the palatal wall of the tooth to close all the gap from the buccal to the palatal wall. And this at the delivery before cementation. You can compare easily. This was the wax up, and this was the final ceramic case. The veneers were tested on the model. We test the fitting, we test the harmony between the teeth, we can test the contact points, the fitting, the margins, and even the morphology and the shape. So here we had a pure imitation of the wax up with the finals. These are the final ceramics. You can see the texture, the grooves, and the glaze. You can test everything on the model. Here, the lab technician did an imitation of the wax up. In the case before, the advantage of the digital workflow is that you can scan the situation and adapt the digital wax up you did if it is confirmed by the patient, and this way you are sure technically that you have a pure reproducibility or a real predictable case, and you can easily reproduce the same shape that you get on the wax up. So this is the thickness of the temporary 0.7, and this is the thickness of the ceramic, which is 0.7, which is mean we had a full matching even in the thickness with in this case. You can see the texture here, how thin is our veneer, the surface texture, the grooves, the glaze, and etc. So you can use easily or what we taught initially, the conventional way, give your lab the parameters, and then from there ask the lab to give you the details in the wax up and try to imitate these with the ceramic. Or you go from the beginning, the digital way, you scan the teeth, you do a digital wax up, and after taking the impression digitally of the prepared teeth, you can match or do a mirroring between the digital wax up and the final desired shape, and from there you can mill your ceramic. You can see the details of the veneer, the small details in the texture, the glaze, how thin is the veneer, and how accurate was the work comparing with the temporaries. Pigmentation is not our topic for today, but few words about that. It's a must to retract the lips and the jaws. Here I used my Optragate, and then the application of the universal bond, and so on. And fitting of the veneers with Optra Sculpt to be sure that the veneers are well placed, then covered with the glycerin oxygen inhibitor layer before polymerization. The cementation day after cleaning. We can see the integrity of the ceramic in the soft tissue after 1 week, and we can evaluate here the shade, the shape, the small details, and the relation between the teeth with the lips and the full smile, and how we reduce the buccal, the black triangle on the buccal corridor. I would like to thank here Finish Line Dental Lab for this very nice job. Here the case before cutting, after small non-invasive, real non-invasive, small thin finish line, and here is the case after the cementation session. Thank you for your participation and hope to keep in touch.